everyone, and welcome to the Flatlining Podcast from Fulcrum Strategies. I'm Matthew Handley, and with me is our President and CEO, Ron Howergan. Ron, how are you?
I'm good, thank you.
We're going to be talking about some drug and health economics today, and whether or not Medicare should be covering every drug that is approved by the FDA. We're talking about two government agencies, and we're talking about an agency that pays for a lot of healthcare in this country. And this is based off of an opinion piece in Real Clear Policy by Howard Dean. And Howard Dean is the former Democratic governor of Vermont and the former chair of the Democratic National Committee. And he has obviously lobbied fairly hard to remove some of these administrative decisions that are in place at Medicare to barring certain drugs from being approved. And we've talked a little bit about this before, Ron, and I know you've shared your personal experience before, because this all surrounds right now a lot of these Alzheimer's drugs that have come out in the last couple of years. We talked before about one that was approved by the FDA, and Medicare basically said, no, we're not going to cover it. And I guess we'll start up and back up a little bit there and talk about what the reasons were for Medicare not wanting to cover it.
Well, the first thing you've got to understand is what FDA approval means, okay? And a lot of people, I think, put a whole lot more into the meaning of FDA approval than what probably should be. What the FDA approval is and what their job is to make sure that, first of all, that a drug has an effectiveness to it, that it does what it's supposed to do. If it's supposed to lower your cholesterol, does it really lower your cholesterol? If it's supposed to slow down the advancement of Alzheimer's, does it really do that? In clinical trials, does it show some value? And I say some because it doesn't mean it helps everybody, and it doesn't mean that it helps everybody a lot. It just has to show some clinical value. And then the second hurdle is, does it either have very little or no harmful side effects, or is the value greater than the side effects? Does it offset the side effects? So obviously, if the FDA is approving something for headaches, okay, that's a pretty low threshold of side effects because we got a lot of things that will treat headaches. Okay. If it's a drug that is let's say a cancer drug, and it's going to, help me survive cancer, and the side effects are my hair is going to fall out, and I'm going to feel like crap while I'm taking it. Well, that's probably okay because of what the value of curing, of me living is. So the FDA is not saying that this drug should be used for everybody or even anybody. It's just saying it's clinically effective and its side effects are either low or compared to what it's doing clinically are okay. There's a cost benefit from the clinical side to it. The problem is people look at the FDA and say, well, it's FDA approved. That means everybody should get it. That's not what the FDA is doing. And that's a whole different question, in my opinion.
And you had written previously on our website, and we'll put the link in the show notes, about Aduhelm. And that was the one I was thinking of, that the name escaped me. And that was one where it cost nearly $30,000 a year from manufacturer Biogen, and CMS said they weren't going to approve it. And part of it was it wasn't very effective at all, even though I guess it showed some effectiveness in some people. You can speak a little bit more to that than I can.
It was a drug that even in clinical trials, the people who were doing clinical trials were like, this really doesn't do a whole lot. Some people did show some, slowing down of the progression of the disease. And it was extremely expensive. And so that's really why CMS, and largely CMS was sort of almost driven by the neurologic community the physicians were saying, I'm not going to do this because it really, for the cost, it really doesn't have a cost benefit to it. And that was probably one of the first drugs that CMS said no to, even after it had FDA approval. And I think it was the right decision. It wasn't a good drug to be put out there in mainline because it really had limited effectiveness for what was really a massive cost.
Right. Former Governor Howard Dean, we were talking about this post that he had on Real Clear Policy. He seemed to think that there is a complete stop at the Medicare level of any sort of Alzheimer's drugs that were based on monoclonal antibodies. And he said that this goes back to a concern from FDA in June of 2021 over an accelerated approval of a different monoclonal antibody used to treat Alzheimer's. And the new drug that he's talking about here is Leqembi, and that one is also a monoclonal antibody, but he's complaining about the speed that it went through because of the agency's decision to slow down a lot of those. I just threw out a lot of terms that a lot of people might not be familiar with. So, Ron, if you want to speak to any of those and kind of break them down for our listeners, I know that they would be appreciative of that.
Yeah. So, and there has been, I think, a more heightened awareness of this class of drugs because there's Leqembi's coming out. There's one behind it. There's a lot of research in this area, and there should be. Alzheimer's is a horrible, horrible disease. My father had Alzheimer's toward the end of his life. He had that, and he had cancer too. And it's heart-wrenching to. I mean, I can remember having the conversation when he was still pretty coherent, and him asking me what it was going to look like. You know, where is it going to go? And I can remember having to tell my own father that there would be a time when he would not recognize me. That's a horrible thing to do, and it's a horrible thing to watch somebody go through. So this is nothing about that we shouldn't be looking at this stuff. But the question becomes, how much money are we willing to spend? Because we only have a limited amount of it. And there's a lot of other things we also need to spend it on. And for what benefit? And that's really what I think the slowdown was. We have to make sure that these aren't just, a small percentage of people that have benefit, that they're really doing something. And what they're trying to do, and what monoclonal antibodies are trying to do, is they're trying to slow down the progression of the disease such that the patient will die of old age before they ever have the problem with being, severely impacted. Because if we can do that, we've done something enormously helpful. But we've got to make sure that that's really what we're doing, because what we don't want to do is break the bank on something that is really going to have very little impact on the progression of the disease. And that's what they're asking for is what really impact is they're having for this kind of cost.
Former Governor Dean wrote that the Center for Medicare and Medicaid Services agreed to cover monoclonal antibodies such as this drug, Leqembi, as long as patients enrolled, or the doctors of the patients enrolled them in a registry. There was some fear about bureaucratic hurdles with that, but he even says that apparently it seemed to be pretty easily navigable. Is that something that should be done in general for any drug from the Center for Medicare and Medicaid Services? Should they require people to register in order to get access to a particular drug?
Well, there's the reasons for the registry are several. Okay, first of all, in order for you to really have benefit, it has to be early onset, because what it's trying to do is slow down the progression of the disease. And if the disease is fairly far advanced, it really doesn't help. And so how do you make sure that it's only be given to the right people? One of the ways to do that is through these registries, to where the doctor has to input information. And there are several tests that can be done that have to be put into that registry to determine that, yes, this really is early onset Alzheimer's, and it's likely to be impacted. It has a much higher chance of being impacted positively by this drug than somebody who's more advanced. So that's number one. The other thing is, a lot of these drugs, and it's similar with some of the drugs that are used to slow down the progression of MS, very similar kind of a thing.
Right.
A lot of these drugs have some very, very serious potential side effects that you have to be very careful of. The MS drugs, for example, you can develop PML. PML is fatal. And so one of the things these registries do is say, okay, we're going to do the following check. In the case of the MS drugs for PML, it's you get an MRI every 6 months for some of these drugs, so that if we see PML starting to develop, we take you off that drug so that you don't develop it and then die from the administration of the drug. So it isn't just about government control, or we want to keep track of who's on there or limit the number of people on there. Really, these registries are designed around making sure it's the right patient and that the doctors are giving the right test and looking for these potentially fatal side effects. That's the reason for the registries.
Let's zoom out, talk big picture here, and talk generally about different drugs. Because there's this general question, and you hear it a lot from, you could say you hear it a lot from conservatives, but you hear it from all sides on occasion. And is that, what role should administrative people at an organization like the Centers for Medicare and Medicaid Services have what sort of say should they have over drugs that are covered by Medicare that are approved by the FDA?
Well, so that gets into a question.
And it gets into the insurance question as well, I know, and we'll get to that in a second.
Yeah. Yeah, it gets into the question of, do we want a system where as long as the drug can clear the clinical hurdle of it, may have some benefit and either has low side effects or the side effects are much less than what the benefit is. That it has a a ratio there that works. That we should just cover it, cost be damned, or should things like cost and cost compared to the benefit be part of the equation? Now, I would argue that one of the reasons why Medicare is going bankrupt and has a date at which it'll be insolvent is because we've not looked at the cost benefit analysis enough. Okay. In addition to the fact that, we have this weird way that we allow the manufacturer to set the price. So yeah, if you just want to say, hey, everything should be covered, then fine. But then don't complain when Medicare goes bankrupt in a few years.
Right.
If you don't want Medicare to go bankrupt, we're going to have to start injecting cost into it. And unfortunately, there will be some things that will say, hey, that's good, but it's not worth that much money. And that's just the reality of it. Mm-hmm. We have that in almost every other part of society.
It's interesting because last week we talked about the weight loss drugs. And now let me ask you this. Are any of the weight loss drugs covered by Medicare right now?
I don't believe so yet.
Okay.
But I'm not sure.
So then this goes into the same sort of category then. Is it's a decision of it's too expensive right now or they don't see the benefit there for covering it by Medicare or Medicaid. Let's talk about, we talk about the administrative role in something like CMS. How is it any different or should it be different from commercial insurance determining what drugs they're going to cover? For example, if a drug's covered by Medicare, why shouldn't it be covered by your commercial insurance?
Well, so yeah, I mean, when you add the commercial insurance part of it into it, then you've got, the issue that we just, that we talked about last episode with Wegovy, where it's a cost benefit to say, well, I don't want to solve obesity if it's going to cost me more money to solve it than I'm going to save. Right. And the profit motivation of the insurance companies creates a weird scenario there. So I don't like that whole profit motivation on what gets covered or not covered. I think the whole system needs to be changed on what gets covered and not covered so that if it's covered by Medicare, it should be covered by everybody. And it shouldn't be, well, Blue Cross covers it, but United doesn't. Mm-hmm. If something is a good thing to do, if let's say that the price of Wegovy came down and we said, you know what, this is a good thing to do. We got 15 million people in this country with obesity. Or if we realize that the next drug for Alzheimer's that comes down the pike says, hey, this really does slow it down a great deal. And at that cost, it makes sense for us to do it. Then it should be covered, period, end of story.
Right.
It shouldn't matter who the payer is. But we've got this, weird fragmented system now where some do, some don't, and some have different rules on who covers what. That has got to change, because if you present with some clinical presentation that says this is an effective, cost-effective, and clinically effective treatment for your situation, it shouldn't matter whether the government's paying for it, your employer's paying for it, who your carrier is, or if Medicaid's, it shouldn't matter. If it's the right thing to do, it should be the right thing to do.
The last question I want to bring up, and someone might accuse me on Twitter of rehashing the 2022 election, but I'm not, I promise, because that election seemed to be about COVID, which it shouldn't have been in some states, including my home state of Michigan. And but I want to ask this question because it talks about what role should administrative officials have in government, because you have the idea that should administrative people be making decisions that are contrary to what doctors might be making. And so I guess the question is how is it, or is it different from administrative officials, making COVID or other healthcare decisions when CMS says they're not going to, or an insurance company says they're not going to cover a particular drug?
Flesh out for a little bit, like the scenario you're sort of talking about. I want to
sure. I mean, you had some people, particularly on the right, criticizing different government agencies for having too much power during COVID, and who were some of these administrative officials making all these decisions? People that sit around too long. Right now, you've got criticism about the FBI making different decisions, but that's more of what I'm aiming at here. Yeah.
So, I think my own opinion on this is our system is flawed, but it's the best system out there.
Yeah.
As flawed as it is. Because administrative people who, let's say, go beyond their scope and make decisions they shouldn't, can be overruled by the courts. So we have that checks and balance from the court. If the elected officials that put the administrator in place for, let's say, a position like the head of CMS or the head of, HHS or whatever, if they make bad decisions on who they put in those roles, then that elected official doesn't win the next election.
Right. Yep.
Now, it's slow. And there are times when definitely people get caught in the middle. And I know there were doctors who felt like, there were people in certain administrative positions making decisions that didn't make intelligent clinical sense. And I'm sure there were. Mm-hmm. But it's the best system that I've seen out there. It's just, how do we make it even more efficient?
Right.
And the flip side of that is there were doctors who were making decisions that were not very clinically wise to do.
Yep.
And some administrative officials overruled them. And so it's one of those things where it's always going to be messy. There's always going to be anecdotal examples of, boy, that shouldn't have happened, and those are real. But overall, the system kind of works.
Yep.
Well,
and to anyone who thinks that they can just eliminate bureaucracy completely, I mean, you have to have some sort of administrative level, some sort of bureaucracy in any organization, healthcare included. I mean, you look at a hospital, for example, you can't just run it with only the doctors here. You've got to have people that can maintain the bills, people who can do the accounting and all that sort of stuff. So it's required anywhere. Of course, I think there's a legitimate concern is it too big in the federal government?
Oh, yeah.
That could be a conversation for another day.
That's a whole couple of day conversation right there. Yeah.
Well, Ron, we're about out of time on this episode of the Flatlining Podcast, so thanks for sitting down with us again.
Great. Thank you.
You can follow me on X at Radio Handler. You can follow our president and CEO. He's on X as well, at Ron Howerton. Be sure to subscribe to the Flatlining Podcast from Fulcrum Strategies so you never miss an episode.